Coronavirus hospital admissions were up a fifth to 609 yesterday. The NHS Confederation speaks on behalf of hospitals and other organisations that plan, commission and provide NHS services in England, Northern Ireland and Wales. Danny Mortimer is their interim chief executive and he joins us now. Good morning.
Good morning.
Do you agree with the head of the Royal College of Emergency Medicine that the NHS risks implosion this winter?
We are absolutely at a critical moment now. We have done sterling work, our teams have done sterling work to resume many of our non-COVID services over this last few months. But those rates of admission that we're seeing in terms of COVID positive patients, particularly in Liverpool and the North West, and the fact that we know that from November onwards the incidence of flu and pneumonia will also increase, do mean that we are at a crucial moment. The government needs to have much clearer and much more decisive action in terms of necessary restrictions for us as members of the public, but we also need to play our part as society in general. We do need to follow that hands, face, space guidance really strictly now. Because we are absolutely risking placing that kind of pressure that the good doctor has described in terms of the NHS, overwhelming the NHS, but we're obviously also posing serious risk to our loved ones if we don't follow the rules, follow the guidance.
We heard just there the South Yorkshire Mayor, Dan Jarvis, saying that he had been speaking to Matt Hancock, the Health Secretary, asking him, please give the NHS what it needs for this winter. What are your members telling you about what they need to see it through this winter, to not implode, as the head of the Royal College of Emergency Medicine has warned?
So I think the public can be reassured that we are in a much more resilient place than we were back in March and April. There does seem to be greater resilience, greater certainty about PPE and drug supplies. Our fantastic clinical teams, our researchers understand the virus and its treatment a bit better. There are new things that we're doing that we've learned over the spring that enable us to manage the severity of the disease, and trials are ongoing in terms of other things that we hope might also make a difference in terms of managing patients. But again, unfortunately, because of the way the virus is accelerating, we're going to start to make choices soon about non-COVID treatments. But as I said, we've learned a huge amount during the spring. We've got the same fantastic teams in place. Clearly, they are also not immune. We run some risks in terms of colleagues contracting the disease. But we are doing everything we can. Services are doing everything they can to plan for this next phase.
What did you mean then, where you said you might soon have to make choices about your non-COVID treatments? What did you mean by that?
Well, We've over this last few months, we've restored about 80% of the non-COVID treatments that we provide to patients. And we've got this really interesting balance now. There may be circumstances where we need to move staff into treating COVID patients because they've got particular skill sets that we need. But we also do want to make it very clear to the public that if they are worried about symptoms that they have, for example, cancer symptoms, potentially, that they should contact their GP. There are ways in which we can maintain safe treatment for our most urgent patients. So, we've got to strike that balance between prioritising COVID, but also making sure that we can prioritise access for people who've got the most serious, potentially serious conditions.
Trying perhaps desperately to look on the bright side here, is there not a possibility that given social distancing and given the fact that people are not going out, that flu and pneumonia cases, you say we're going into flu and pneumonia season, that they will be significantly down this year?
I suppose the honest answer is none of us really know. We very much hope that there may be that kind of factor, but we don't know. And there are lag times and lead-in times to all these things. We do need to see that much clearer set of decisions and guidance in terms of how we live our lives in the coming months. That will make a difference. We all have our part to play in terms of following the guidance, particularly around distancing, keeping our hands safe and wearing a face covering when we leave our homes. But we are at that critical moment now. I think particularly in certain parts of the country, talking to colleagues in the North West and Merseyside in recent days, they're seeing really rapid rates of admissions now. There are 200 patients in the Liverpool hospitals who are COVID positive. There were 100 COVID positive patients this time last week.
What use, if any, in England are the Nightingale hospitals, which remain on standbys, 7 of them in England? Are they a useful resource?
I think if we reach the point where we are overwhelmed with COVID patients, then they give us really important extra capacity. We are at a place where we do have much more developed plans to move patients between institutions if necessary, so that we can try and maintain those non-COVID services that we were just discussing, Luke. But it's important that they're there. You know, that it's important that they give us that safety valve if the virus in certain parts of the country proves too much for the capacity that we've got available in our mainstream hospitals.
And just explain for whoever's listening what your worries are in terms of capacity in the NHS. Specifically, if we look at areas like Manchester, Liverpool and Newcastle, where hospital admissions are particularly problematic at the moment. What is the crunch point? Is it the same as before? Is it about intensive care beds? Is that the worry? Or is it just general hospital capacity?
So patients who are admitted with the virus, many need assistance with their breathing. Not all of that is in intensive care. We have a number of different treatments depending on the severity of the impact of the virus on the patient. So yes, the biggest risk is that that available capacity runs out, frankly, and that's both a function of the equipment we have available, but obviously also the skilled staff that we've got available to look after those patients. There's also, I suppose, something though to stress for the longer term, which is that backlog that we've seen grow in terms of treatment for non-COVID patients. Our waiting lists, our waiting times are much, much higher than we want them to be and the public want them to be. That's also a point of crisis for us for the longer term. And we will need assistance from the government, both, yes, in this immediate term, as Mr. Jarvis talked about, but also over this next couple of years as we get past the virus, hopefully, and also then try and make good the waiting times and treatments for patients who are experiencing delays because of this last 6 months.
We had news this morning that NHS Test and Trace had its worst week ever in terms of being able to contact the close contacts of people who had tested positive for coronavirus. Does Test and Trace's failure make your job harder?
In simple terms, yes. This point where we're talking about this rapid growth in the spread of infection, you know, rates of infection now are 7 times higher than they were at the end of August. What we see from international experience is that the sort of really effective tracing of contacts and isolation of contacts is a really crucial feature of slowing and reducing the spread of the virus. And clearly it's not the only thing that needs to happen, but it clearly hampers the ability of the country to manage and to flatten that curve of growth in terms of the spread of the virus, particularly as we head into winter.
Danny Mortimer, interim Chief Executive of the NHS Confederation. Thanks very much for your time this morning for talking us through all of that.